Today I'm going to be telling you a little bit about Parkinson's disease. Parkinson's disease is a progressive neurological disorder. It affects approximately 1% of the population over 50, but prevalence increases with age, affecting 4% at the age of 80. It affects both males and females with a slight male predominance. The main features of Parkinson's include tremors. These take place when a person is awake and sitting or standing still. They're called resting tremors, and they usually get better when the person moves that part of the body that is shaking. Another feature is muscle rigidity. When muscles become rigid, they may feel tired and ache. Muscle rigidity can also cause a reduced arm swing. Other features are bradykinesia, which is the reduced speed of movement, and hypokinesia, which is a reduced range of movement. These reductions of movement can affect balance. They can cause a person to have a shuffle-type walk, posture can be affected, and they may even experience a brief inability to move. Secondary features include depression, dementia, troubles with swallowing, hypokinetic dysarthria, and micrographia. So let's take a look at the brain and see what happens here with Parkinson's disease. The basal ganglia is a group of cells that are related to motor behaviors. It consists of the caudate nucleus, the putamen, and the globus pallidus. Damage to this area can cause Parkinson's disease. So here are the structures that we are going to be talking about, which include the basal ganglia, and they make up the direct and indirect pathway. The direct pathway is the movement pathway, and the indirect pathway is the pathway for stopping movement. It consists of the striatum, which has two parts, the caudate nucleus and the putamen, the globus pallidus, thalamus, and substantia nigra. The substantia nigra also has two parts, the pars reticulata and the pars compacta. The pars compacta sends messages to the striatum through neurons rich in the neurotransmitter dopamine, and it is the area that is affected in Parkinson's disease. So let's take a look at how all of this works. And to do so, we are going to start with the normal brain to muscle communication of the direct pathway. So here we see that the globus pallidus has a direct connection with the thalamus. The thalamus would like to excite the motor cortex to create muscle movement. It is the job of the globus pallidus to keep that from happening. This red arrow represents the inhibitor neurons, which are keeping the thalamus in check. So if we want muscle movement, then the motor cortex sends the excitatory neurotransmitter glutamate to the striatum. This excites the inhibitory GABA neurons in the striatum, and they in turn send out an inhibitor to the globus pallidus. This inhibits the globus pallidus from inhibiting the thalamus. With this reduction of inhibition, the thalamus is able to communicate with the motor cortex. Once the motor cortex has been excited, it sends a message to the muscles. And we get movement. However, in order for this movement to be smooth, we need to look at the substantia nigra. The substantia nigra acts like a volume dial, turning movement up and down. Here's how it works. The substantia nigra will send dopamine neurons to the striatum. These neurons in the striatum have dopamine receptors called D1 receptors. As they receive signals from the dopamine neurons, they get excited, which causes an increase of inhibition being sent to the globus pallidus. So, dopamine being sent to the striatum turns the movement up, and as the movement needs to slow, dopamine neurons will decrease. Let's do a quick review. The motor cortex says, "I've got to get moving," and sends an excitatory message to the striatum. This excites the inhibitor or GABA neurons, and they send a message to the globus pallidus to stop inhibiting the thalamus. This allows the thalamus to excite the motor cortex, and the motor cortex excites the muscles. The substantia nigra sends dopamine neurons to the striatum, which modulates the excitability of the neurons that are headed to the globus pallidus, helping to increase inhibition. The more the globus pallidus is inhibited from inhibiting the thalamus, the more the thalamus can excite the motor cortex. Dopamine signals increase or decrease depending on the type of movement that you want to execute. So let's take a look at what happens in the direct pathway for someone who has Parkinson's disease. For people with Parkinson's disease, dopaminergic neurons begin to die off. By the time the physical effects of Parkinson's begin to show, 80% of these neurons are dead, and the remaining neurons contain a spherical neuronal inclusion called Lewy bodies. With this breakdown of communication, movement becomes disordered. So the lack of dopamine-producing neurons causes this communication breakdown. But what role do the Lewy bodies play? Lewy bodies are an abnormal collection of protein found in nerve cells. They have been linked to problems with thinking, movement behavior, mood, and dementia. Lewy bodies are not just found in Parkinson's, they are also seen in Alzheimer's disease and Lewy body dementia. 36% of Alzheimer's patients have Lewy bodies at autopsy. This is called a Lewy body variant of Alzheimer's disease. All Parkinson's disease patients have Lewy bodies present in the dopaminergic neurons, and Lewy body dementia is the second most prevalent cause of dementia after Alzheimer's. It is described by its distribution of Lewy bodies in the subcortical and cortical regions of the brain. Lewy body disorder is widely underdiagnosed, and in fact, it was unknown until after autopsy that the comedian and actor Robin Williams had Lewy body disorder. It would appear that Lewy bodies may play a role in the cognitive and dementia-related effects of Parkinson's. So, there is some exciting research on the horizon. The drug nilotinib is an approved medication for treating leukemia patients, but researchers from Georgetown University Medical Center believe it may be useful in treating Alzheimer's and Parkinson's disease patients. The drug nilotinib works by eliminating toxic proteins. The drug activates a mechanism in the brain cells that work to degrade these proteins. Subjects for this trial are being gathered now, but researchers hope to prove that nilotinib will remove Lewy bodies and keep dopaminergic neurons from dying, and improve motor function. That's pretty exciting stuff. Hopefully they'll get the results that they're hoping for. Now I am going to tell you about a treatment that is already being used to keep the symptoms of Parkinson's disease at bay. Patients with Parkinson's have to take many different kinds of medications to help with their symptoms. For some patients, a surgery called deep brain stimulation may be an option. Here's how this works. Electrical currents target abnormal brain activity, and this triggers blood flow, leading to the release of neurotransmitters. Using images from an MRI and a CT scan, doctors locate the area in the brain that electrical connections will be sent. Electrodes are surgically implanted in the target area of the brain using a lead, which is a long probe. A wire attached to the lead runs under the skin from the head down the neck and to the chest, where it connects to a pulse generator. That will generate electrical impulses, sending them to the brain. A neurology specialist will adjust the strength of the pulse, how long the pulse lasts, and how quickly it's fired. This deep brain stimulation provides relief from the primary motor movement symptoms of Parkinson's. So now that we know a little bit about Parkinson's disease, let's take a look at how it affects speech and swallowing. Parkinson's patients show swallowing difficulties at all stages of the process. During the oral process, trouble with initiating tongue movement can occur. Also, a rocking pattern is often seen that prevents the bolus from entering the pharynx, which halts the initiation of the swallowing response. Patients often have problems with aspiration, which can occur chronically without external signs such as coughing. This can lead to pneumonia, the most common cause of death in Parkinson's disease. Other issues include difficulty with soft palate function, poor laryngeal closure, reduced pharyngeal peristalsis, which is the constriction and relaxation of muscles that helps move the bolus along the tract. With correct timing and dosage, there are medications that can help with these symptoms of dysphagia. The effects that Parkinson's has on speech vary depending on what stage it is in and how effective the medicine is, but I will discuss some of the problems that can arise. Our book discusses a study done on different aspects of speech in Parkinson's disease patients, and here is what they found. 89% of patients were noted to have laryngeal disorders, with hoarseness being the most prevalently perceived characteristic, coupled with breathiness, roughness, whispered aphonia, dysphonia, and hypokinetic dysarthria, with monotone pitch and mono-loudness being a common characteristic. Articulatory errors were seen mainly in manner of articulation, affricates, fricatives, and stops being most affected. Inadequate tongue elevation causing narrowing of the vocal tract seemed to be the reason for these articulatory changes and are called articulatory undershoot. 10% of patients showed hypernasality. 20% of patients showed to have a rate disorder. 10% were seen to use syllables that were too short, 6% used syllables that were too long, and 2% had abnormally long pauses. And repetition of phonemes and syllables is also a disfluency noted in Parkinson's. In looking into the aspects of speech in Parkinson's disease patients, the predominant characteristic is lack of prosody with respect to emotion. This monotonous speech has been thought to be a symptom of the motor aspects of Parkinson's caused by akinesia and rigidity involving respiration, phonation, and articulation. However, some research now suggests that it may be due to a receptive disorder or related to the symptoms of depression. These studies have found that patients with Parkinson's show a decrease of emotional prosody prior to the motor-related hypokinetic dysarthria. Also, when asked to imitate emotional speech, they are able to perform the request near normal. This would indicate that these changes in emotional speech are not motor-related. Similar speech has been observed in those who suffer from depression, but another study implicates a receptive disorder as the cause, saying that patients with Parkinson's are unable to appreciate the emotional aspect of others' speech and facial expressions, as well as their own, which may be the underlying cause of their dysprosody. Speech therapy aimed at improving prosody by facilitating the use of visual, auditory, and tactile feedback have proven effective in helping patients monitor their own speech, which improves prosody and increases their intelligibility. All right, that is all I've got for you today, but here is a list of resources and links if you would like to check some of this out for yourself. Thanks for listening.